Hi, Jack Cush coming to you from Vienna, the last day of Eular 2024. It's been a great meeting. I want to give you an overview of a session at the end of yesterday, a Eular session, where they presented the Eular points to consider when managing inflammatory arthritis patients who happen to have a history of cancer. As you know, this is one of the more complex issues you deal with. It's a little fuzzy as to who recommends what. And often I get a lot of calls from you and your colleagues about what to do. And I've studied this a long time. I awaited these recommendations. I think they're pretty good. They're not without their limitations. And I think the presenter of these points to consider, Professor Gottenberg from France, certainly was forthright, admitting they don't have all the answers. And what they tried to do was answer the question of, when you're faced with a patient who has a history of cancer that's in remission, what's your prescribing going to be if you're treating inflammatory arthritis or inflammatory bowel disease? It doesn't really matter. Let's talk about cancer scenarios in general before we get to these guidelines. So there's a few, right? Do these drugs cause cancer? Do these drugs cause recurrence of cancer? Do these drugs cause people with cancer to die from cancer? So the last one is true. That means it's not even close, meaning that if a cancer patient's given a biologic, there's no evidence in play anywhere, and it's been studied, that giving our drugs causes them to die of their cancer any sooner, right? It's arguable about whether these drugs cause cancer, because when they are mentioned to cause cancer, it's on a background of a disease that's got inflammation that causes cancer. So RA patients are at higher risk of cancer. And all the cancers that have been associated with the drugs that you use are the same cancers that happen in RA patients bad enough to get biologic drugs or targeted synthetics. So it's an increased risk of lung cancer, of skin cancer, of lymphoma. So is it the drug or the disease? It's the disease and inflammation. So the last issue, I think, is, again, is there a problem of recurrence? And they try to address that in these guidelines. So the first thing that they did was they have a 27-member task force, largely European, 2 patients, 25 rheumatologists, a few people who are methodologists, a few who are expert at oncology. They did a systematic review. They sort of came up with 15 new studies that were mostly RA-centric, looking at outcomes when RA patients got treated with biologics, targeted synthetics, whatever, and what happened to their cancer. They had 2 IBD studies and 1 study that was in IMID, a bunch of inflammatory disorders. So their overarching principles were basic, shared decision making, treat the target, whatever. Nothing really new there. There are 8 points to consider, and I'll go through them and some discussion of them. So the first one, they recommend that effective treatment of inflammatory arthritis is important to reduce the risk of malignancy, kind of going to the point I just made. Inflammation drives malignancy risk. Controlling the inflammatory disease will theoretically lower inflammation risk. There's old studies by Bakeland and others in a Swedish database showing that the highest levels of disability were associated with a 71-fold higher risk of cancer. So this is an important point, and meaning that you can't stick your head in the sand when someone's got a history of malignancy. You got to treat your disorder that you're expert at. The second point, this was a confused point. I'm just going to read it. It doesn't really make any sense. Complications of untreated arthritis needs to be counterbalanced against the risk of therapy-related cancer recurrence. I don't know what that means, but obviously this is a risk-benefit sort of statement. We'll go with that. Number 3, rheumatologists should be engaging in the process. They should be consulting with those who are caring for the patient's cancer, if not the oncologist, and be a decision maker, an advisor in this process. I thoroughly recommend this. 4, anti-rheumatic therapy can be initiated without delay in patients with cancer that's in remission, especially if it's within 5 years of the cancer diagnosis. There's a lot of misconception about how long you need to wait when there's a history of cancer, even though they may not have cancer currently, that they're not fully out of the woods until 5 years. If they need arthritis treatment, and it doesn't matter, they need arthritis treatment. And they're very bold in saying this. They showed forest plots showing that when therapy was initiated before or within 5 years of the cancer diagnosis, there was no greater risk of recurrence or new cancers. So they feel comfortable in making that statement, and I thoroughly endorse that. Number 5, in patients with a history of cancer, JAK inhibitors and abatacept should be used with caution, and they recommend only be used in the absence of alternatives. Why? And so there's a little bit of discussion on this. We need to see the paper on this. But the first point makes sort of sense. The recent JAK warnings and results of the oral surveillance study suggest older patients on JAK inhibitors may get more RA-associated cancers, skin, lymphoma, lung. Okay, so maybe you want to, not make those your first choice, right? Especially if there are alternatives. What's the story with abatacept? Abatacept came into the market, 2012, I think it was. No, maybe before that. But with a certain warning about cancers, maybe lung cancers, and it's never been borne out by other large studies or observational studies. But more recent data from 2017, 2019, 2022, there are some reports suggesting 5 out of 6 reports, observational reports, when abatacept was used in RA, there was a higher risk of cancer with some low significant increases in the hazard ratios of one study was 1.02 and ranging all the way up to 2.12 as a hazard ratio. Again, these are relatively new studies regarding concerns about abatacept, and I think that, you probably should use other drugs, for which is a lot of data where those need to be concerned, and mainly we're talking about TNF inhibitors seem to be much, much safer. They do say that in patients with a history of solid cancer, that they thoroughly endorse and recommend anti-cytokine therapy, meaning mostly anti-TNF drugs or anti-IL-6 drugs. The anti-TNF drugs, there's unbelievably large data to support that. The IL-6 inhibitors in that situation, I'm not as well familiar with, but they felt strongly in making that statement. So we're talking solid tumors, right? Pancreatic cancer, breast cancer, prostate cancer, colon cancer, skin cancer, right? And and this is old now, the ACR guideline said that patients with solid cancer should be treated as if they don't have a solid cancer, meaning it doesn't matter, that there's no higher rate of recurrence regardless of the biologic you use. That's the ACR recommendation from 2018, I think. These newer recommendations now from Eular say use an anti-cytokine therapy, right? And I endorse that. The next point, number 7, if the patient has a history of lymphoma, and if it's appropriate, B-cell depleting therapy, meaning rituximab, is preferred over other available options. And then the last point they make is active inflammatory arthritis and cancer that's not in remission. The therapeutic choices so it's an active cancer, a new cancer, right? The therapeutic choices needs to be shared decision making between the patient and you, the rheumatologist, and the oncologist about what to do. And obviously they don't have a wealth of information about that. So they did talk about their research agenda. They did talk about the melanoma story. Dr. Gottenberg, when I asked him about melanoma, he said, well, you can use TNF inhibitors in the face of melanoma, and there's no evidence that increases new melanomas or recurrence. But he did state that on the recurrence of melanomas, that there's a lack of data and that they're going to study that. So melanoma still is a bit of a cloudy issue. Again, I recommend use whatever drug you need to use to control the arthritis and leave the cancer to the oncologist, and they can use checkpoint inhibitors or whatever and successfully manage that. Anyway, I think this is an advance. I think it goes to the strength of what is, I believe, overwhelming data about the safety of TNF inhibitor use in patients with a history of cancer. And it goes to the same rule we use in pregnancy. The patient has to be really well controlled if you want to have a great outcome in pregnancy. And you use whatever drugs you need to use that you know to be safe. and there are many in pregnancy. The same here is true in cancer. So that's it for Eular points to consider on managing patients with cancer. There are other recommendations. Tune in for more from Room Now.